Thank you all for joining us for the Merrimack Valley Chamber Annual Fall Business Expo Health and Wellness Fair right here at the Doubletree. It's always great to start this program with our annual healthcare forum. We have a lot of great speakers today who'll be introducing soon. I just want to start by thanking our sponsors for this morning's breakfast, Mass General Brigham Health Plan and the Health Connector for Business. So I just want to say thank you to them. I also think I introduced myself. Yeah, I'm Mike Bevelak, the Vice President of the Merrimack Valley Chamber. Knowing a lot of you in the room here. I just want to remind you that the expo itself will be running right after this program. You can head right next door, check out the different products and services on display from your fellow members. Now we're going to talk about healthcare. And I want to thank one of our sponsors, Melissa Stearns, with the Mass Health Connector for Business. Andy Furman is also in the room, I believe. Andy, you here? Yep, Andy's in the room also. Andy assists the Health Connector with our member healthcare plan. So if your company is looking for healthcare, make sure to see Andy and Melissa later on today. But with that being said, I'm going to now introduce Melissa Stearns, who's going to open up with a couple announcements about the Health Connector before we start. Thank you.
Thank you. Good morning. Yes, I am Melissa Stearns, and most of you are probably familiar with the Health Connector. We've been serving individuals for quite some time with coverage options through the state marketplace, but the Health Connector for Business was developed, I believe, in 2018 to assist specifically the small business owner in Massachusetts. So we serve any small business that has between 1 and 50 employees who want to be able to offer their employees affordable health coverage options. They can do that through us. There's no fees to go through the state marketplace, and it's great, right? Because it's a one-stop shop for them. Everything's online. It's a very easy platform to use. We have all of the leading insurance carriers on our platform, Mass General, we have Tufts Direct, Blue Cross, you name it, right? So our business models or our choice models allow the small business owner to choose an option that's affordable for them while also giving their employees different choices, right? And that is a benefit that is exclusive to the connector. We have a wonderful wellness program that allows them to save money over the contributions they make towards employee premiums over the course of the year. So a lot of savings there. Small business owners may also qualify for the small business healthcare tax credit when they enroll through us. They meet one of the eligibility requirements. But perhaps, as Michael mentioned, one of the biggest perks to going through the connector is their access to certified brokers across the state. So Andy is a great example for that, and he guides our employers and their employees through everything from the enrollment process, plan selection, and again, there's no fee for employers to utilize any of those resources on our platform. So yeah, if you have any questions or you would just like some more information, I'll be here today, and Andy, of course, is here as well. So say hi.
Thank you, everyone. Let me tell you that over the years, I've found that there are two issues that are number one and number two, and they split every year. And it's either energy and the cost of energy or healthcare. And healthcare is, I think, more confusing to the average small business person than the issue of energy or any other issue that we deal with. So we have this healthcare program every year. We think it's very, very important. We want to say thank you to our great speakers who I ask come to the head table now, if you would. And we'll talk about healthcare and why it's so important for you, your business, your family, and your associates. So please welcome our first speaker, the keynote speaker, Dr. Kyami Mahania. Not bad. He is the Undersecretary of Health for the Commonwealth of Massachusetts, a very, very, very important person for us to know and for us to hear, because this is a person that has discussion with the Secretary, with the Governor, on the issue of healthcare in the Commonwealth. And this is an issue that affects each and every one of you. It doesn't matter the size of the business, the type of the business, where you're located, but this is a very, very important topic. So we're very pleased that the Undersecretary, and I want to say this, it is so easy for the secretaries to say, come to Boston. But I want to commend him for coming out of Boston to be with us when he could have just simply said to us, come visit us in Boston. So welcome our Secretary.
Well, thank you, Joe, for inviting me to be here today. I'm Kyami Mahania. My title is Undersecretary for Health. So the way government works is the secretary is my boss, and then she has two undersecretaries because her title is officially Secretary of Health and Human Services. So I have a colleague who is the Undersecretary for Human Services, and I'm on the health side. So in terms of portfolios, the things that fall in my portfolio are mass health, which is a Medicaid product in Massachusetts, Department of Mental Health, Department of Public Health, and then a number of quasis, of which the Health Connector is a quasi that fall under me. So also many greetings for the administration. I still feel it's somewhat weird for me to say in the name of the Healy Driscoll administration. We are very proud of the work that you do, and we're really excited to have been given an opportunity to talk here. Like I mentioned, I live in the Merrimack Valley. When I first moved to New England, I lived in North Andover, and then I moved to Andover. My kids went to schools in North Andover and in Andover. And then for about a decade, I worked at the Greater Lawrence Family Health Center that Guy Fish is now the leader of. And also for those of you who don't know, Greater Lawrence Family Health Center and Lawrence General Hospital are very tightly linked. And for the last, I think, year and a half that I was at Greater Lawrence, I was also chair of the Family Medicine Department at LGH. So this is really a homecoming for me. Perhaps more importantly, in terms of today's topic, this is the first time in 23 years that I've worked in government. So I started in April. And my last job for 6 years before I became undersecretary was CEO of the Lynn Community Health Center. It's about $80 million business in a year, about 700 employees, but it only comes down to about 525 FTEs. About a 22% turnover rate annually. And in a great year, and I'm speaking like Dr. Fish could be here saying these things, in a great year, if everything went well and everything went beautifully, we had a 2% margin. That's like a fantastic year. But when you made no mistakes and no bad surprises happened. And the other thing that's a little bit unusual about health centers is that no matter how much your costs are going up, you don't get to decide what prices you charge. The price is essentially set. And in health centers, most of us are between 60 and 80% of our business is with government-backed insurance. And so whether it's state or federal, they set the price and you have to live within it. And then one last thing I would say is that the health center where I worked was unionized. So I was CEO of a unionized shop. So that is to emphasize that the difficulties and the challenges that you face running businesses every day is something that I was very intimately familiar with. Dr. Fish was just asking me how my job is going, and I said, well, it's way less stressful than being CEO. So he was a little jealous there. But I would say that one of the things that was constantly on my mind when I was CEO was the cost of health insurance. And we were big enough and we had enough close partners in Lynn that we were self-insured. So that's good and bad, right? Meaning that you get to benefit from the good years, and then you just gamble that the bad years won't be too bad. But it was something that I thought about constantly. What is it costing us? What can we afford to do? What services, what benefits can we afford to wrap into the health insurance that we're offering? What are the quid pro quos that I'm doing? Am I offering more services by cutting down network? Am I right? So those are all questions. And of course, your employees, they just ask for what they believe is best for them. So all these sort of computations that you're making are very difficult. So they only see you as a dollars person who's making dollar decisions as opposed to making healthcare decisions. And that was always one of my biggest pain points, particularly in bargaining years. When I was hired for this job, Governor Healy made it very clear. One of her top 3 priorities is affordability. She really wants to figure out how to make health insurance affordable for the vast majority of people who live in Massachusetts. As you know, essentially in Massachusetts, we claim that we have health insurance for almost everybody in the state. But actually, if you look at the numbers of Massachusetts residents who are buying products that are high deductible, meaning I'm not talking $1,000. I'm talking $5,000, $10,000 deductible. The rise in the percentage of people who are buying those high deductible plans is astounding. And the corollary to that is it's not millionaires who are buying that, right? So if you're a millionaire and you have a few $100,000 disposable income every year, it's okay if you have a $10,000 deductible. But most people that are buying these plans don't have that kind of money, and we're seeing an equivalent drop in terms of healthcare use. Meaning that when you buy these products, you're more likely not to go in for primary care, not to go in to seek help for your chronic disease that's at its beginning. So affordability has been something that's been on the governor's mind, and it's one of the charges that Secretary Walsh and her team have to work on. And the other big priority was equity. How do we make sure that everybody in Massachusetts has access and gets equitable care when they do show up? So in terms of affordability, there are no magic bullets. Melissa Stern and Jennifer St. Martins can probably talk about this with much more expertise than I can. But essentially, one of the drivers of health insurance premiums is cost. The cost on the healthcare side is rising, and they pass on that cost to the health insurance companies who pass it on in the forms of premium. And one of the major components of the cost of the rising costs is labor. The cost of labor, you feel it as business owners. Most likely all of you have had to raise the salaries of the people that work in your institutions. It's the same thing for healthcare providers. It is very, very, as an example, at the Lynn Community Health Center, we were trying to recruit a psychiatrist because we were renowned for behavioral health. And actually half of all the providers we had at the Lynn Community Health Center were either psychologists or a mental health worker or social workers. A psychiatrist, we interviewed a psychiatrist who was coming out of residency, meaning no experience, just straight out of the box, right? And we offered $300,000 and he laughed. To come work in a community health center, not have like a big H like Harvard behind their title, means you're starting at $350,000, $360,000. And if you get somebody with experience, you're talking $400,000. And there's no way they're going to generate that revenue, right? But for many places, you just need that psychiatrist in order to have the license, the supervision, and all the rest. So the cost of labor is really astounding. But one thing that's really been troubling, and I'm sure all of you have noticed this, is that there is an incredible workforce shortage. And one thing that surprised me in terms of coming to the state is that it doesn't matter what industry you're in. Whether you're looking for bus drivers, or correctional officers, or childcare workers, or welders, or nurses, it doesn't matter. There's this amazing shortage of labor throughout the state and throughout the industry, and actually it's something that's plaguing most of the nation. And there is no consensus over what's driving this labor shortage. There's lots of opinions, and I'm sure that you all have many, many opinions, but we don't really have a good reason why. We don't have that much data, but a few data points that we have are A, everybody's having trouble filling their positions. B, until actually the post-COVID recovery, we had the lowest adult participation in the workforce that we ever had as a nation, meaning that the number of people who are actually looking for work was at its lowest point. Post-COVID, we actually started to rebound, but that's potentially a reason. But we don't know why. Why is it that adults are opting out of participating? Do we have that much increase in disability? Is it that a lot of people are going part-time because of work-life balance? So the same amount of people are working, but we're all working at 60 to 80%. Those are things that we don't know. Is it because for the last 50 years we've had an incredibly irrational immigration policy? Also don't know. If you look at Canada and Switzerland, so Canada and Switzerland both decide every year, they'll say, we're going to lack 1,000 engineers. And so if you're an engineer out there in the world and you want to come to Canada, you're automatically granted a visa. right? And Switzerland the same way. I was always impressed by the fact that when I lived in Switzerland, almost all the immigrants were way more highly educated than the native people of Switzerland. And that was, right, but is that big enough to drive our labor shortage? We don't really know. But we do know is that whatever it is that we have, it's not working. So whatever the system is, whatever the causes are, the end result is that we don't have enough people to fill these jobs. And so one of the first hires that Secretary Walsh did was she got an ex-hospital CEO to come run a workforce, essentially a workforce team. And the idea is to figure out, for instance, for the particularly direct care professions, so nurses, case managers, medical assistants, what in the stream from training to being hired, what is the block? What is the thing that would actually allow for those positions, for people to start doing the training and wanting to do those jobs? And it's not about creating a new governmental agency. It's really about figuring out, given the existing stakeholders, the vocational high schools, the community colleges, the grad schools, all the educational resources we have in Massachusetts, how do you get them aligned so that we can start building more robust pipelines? Because the system just being left to its devices is not providing that kind of pipeline. And the other component that makes it difficult in terms of healthcare premiums is that we don't have a good definition of value in healthcare. And so, for instance, if you need to buy let's say your daughter is on a traveling hockey team and you need to buy a bag to carry. You've seen those hockey bags, right? You need to buy a bag, right? You as a parent will be like, okay, it's gonna get beat up. It's gonna go from my 70-degree car to the 0-degree rink. Half the time she's gonna forget to put the blade protectors on, so it's gonna like rip through that bag. They push each other all the time. And will you buy her a Louis Vuitton bag for the hockey? No. Like, it's like clear that you'll be like, what's the biggest bag I can afford? That's the strongest. It's the cheapest, right? You're heading to Walmart. Like, you're not really looking for something brand. But in healthcare, there's no way to know what the value of something is. So what people tend to do is they think, okay, who has the best brand name in the business? That's what I want. So one of the reasons that premium is so expensive is that businesses, people, institutions don't have a way of calibrating what they want to pay for the value that they need, right? So I'm not surprised actually that Melissa Stearns is here today, because one of the big drives of the administration is to highlight that through the connector, there are actually products for small businesses that are much, much cheaper than others. But in terms of actual outcomes, in terms of what's the outcome for cancer treatment or for basic asthma management or basic diabetes management, that you are able to get value in your community as opposed to always thinking, no, I need to be in one of the big academic medical centers. Because there are a number of things that academic centers do best, and that you wouldn't want to be somewhere else if you needed it. But that's about 5 or 10% of what healthcare does. And so the question is, how do we convince people that going to Lawrence General Hospital for your mammogram is not sacrificing anything, right? That it's an equal value as any other institution in the state. And so how do we develop that concept of value? And so one of the things, for most of you are perhaps not really aware of what the direction that Medicaid in Massachusetts has been going, and this keeps Dr. Fish awake at night, but about 6 years ago, Medicaid in Massachusetts went capitated, meaning that so in the rest of business normally is you have one visit, you make $200. If you have 2 visits, if you provide 2 visits, you make $400. If it's 10 visits, it's $2,000. Well, Dr. Fish doesn't live under that model. Dr. Fish sends us, he says, I have 45,000 patients on Mass Health, and we look at the risk profile, we look at what we paid in the past, and we say, okay, every month you'll get X million dollars. And it's up to you to decide what you do with that money. And the idea is, once Dr. Fish is controlling that, he may look at a patient who has asthma in the summer and be like, actually what this person needs is an air conditioner. It's not medicine. They just need to have an air conditioner at home so they quit having these crises. And under a program that we have through Mass Health, he's able to do that. So that's one way where we're creating value, in the sense that you say, okay, the people who know best, the people providing the care, the people who know the patients, they get to determine what that patient needs, as opposed to me sitting in my office in Boston saying, well, if you want to do this, I'll pay you 2 cents. If you want to do that, I'll pay you 10 cents. If you want to do that, I won't pay you at all, right? And so that is a big push. So I really, you will see that coming through commercial insurances as well. Meaning this push to go to something, and it's gone by different names, but value-based care is one of the most common names that you'll find. Meaning that insurances were more and more likely to be likely to pay institutions a capitated rate as opposed to a fee-for-service. And the reason for that is to try to define value. Right now, on a national level, we use about 22% of our GDP to pay for healthcare. And when I meet with interim CEO of LGH, she'll tell me I need higher rates. She never says I need lower rates, right? But in terms of nationally, there's just no way as a nation we are going to accept paying 25% of our GDP, 30% of our GDP to healthcare. Because that means no roads, poor schools, right? So at some point, we have to figure out in healthcare, how do we provide value for the money that is being given to us by the system? And then I would say that the other massive challenge that we face is that we call it health insurance, but it's not really health insurance. So as an example, I've been a homeowner for 23 years. I've never used my home insurance, right? I just pay my premiums, and you pay the premiums that expect in case something bad happens. Same thing with my car insurance, right? And I've even had 2 teenagers drive, and I still haven't used my car insurance, right? That is insurance. Health insurance is not really insurance. We're all going to use it. So it's like having insurance to buy gas, right? For your car. We call it health insurance, but we have to really think of it as a different category. It is something that we will use. It is something that all of us, 100% of us, will use. Even if you're super healthy, you will use it because you need preventive care. And then all of us, and if you're super healthy, you'll become old. And if you're old, you're going to use. And speaking as a person who's over 50, I now know that over 50 is old because I use a lot more healthcare, right, than I used to. And so the other big question that we really have for us as a society is, when are we going to choose to pivot from being a system that provides care for people who are sick? Because that's what we're set up with. That's really what we're set up for. Right? That's the reason the most common room in the hospital that our community knows is the emergency room. Because we're set up to provide sick care. And as a society, we're going to have to figure out, how do we move so that we're providing wellness? Because in the end, the only way to really drive down cost is to use the services less. And the question is, how are we going to use those services less? That's probably something that's beyond the scope of this administration. What we're starting with is the biggest robbers of life. So we're going to have a huge concentration of cardiometabolic disease. We're going to have a huge concentration on substance use disorder and its effect on people. And we'll also concentrate on some of the more embarrassing things. It doesn't necessarily take a lot of lives, but it's really embarrassing. So maternal morbidity and mortality. We're one of the worst states in terms of women who die after giving birth. And so as an administration, over the next 2 to 4 years, that's really going to be the focus, to make sure we can move upstream and have some of those efforts be mitigated. But I would say that in conclusion, the challenges that you face as small businesses, meaning both the cost of healthcare, but also access to services for your employees, for your staff, dovetails quite well with what we're thinking of in terms of our priorities, which is how do we illuminate some of the products that we will continue developing, particularly through the Health Connector, in order to have strong value propositions for small businesses in terms of health insurance. But also, how do we help convene and intervene on the labor side so that the workforce increases, so that there's less access problems for your employees and your staff. So thank you so much for being here. I know I went 2 minutes over,
We'll do questions after.
but we do questions afterwards, hopefully, because I know Robin will stick to her time.
I will.
Thank you so much, Doctor. You can see the challenges that he's facing. Thankfully, he's not that old. He's only 50. So we look forward to a successful tenure. And just so you'll know, the Chamber is talking to Secretary Jones. She's the new Secretary of Labor and Workforce Development about being a speaker at one of our Chamber programs. We had the Lieutenant Governor at the Mayor's and Managers Breakfast, and we are talking to the Governor's office about having the Governor come up probably in the spring of next year. But these are issues that we're facing, we're working on, and it doesn't matter what business we're in. Every single business we talk to cannot find the help they need. And we're working very, very diligently to provide that opportunity. Our next speaker, another challenging position, Dr. Guy Fish, the MD. He is the president and CEO of the Greater Lawrence Family Health Center, and you heard a bit about the challenges facing health centers, but I want to tell you that Dr. Fish has really brought this agency back into the community, and I commend him for it. So please welcome our next speaker.
Everyone. Thank you, Joe. And thank you, Kalmi, for wonderful remarks. It is so fantastic having someone in the top leadership of EOHHS who gets it, who understands intrinsically all of the forces, the challenges, the ins and outs, puts and takes that we are all facing in delivering what is a human right, which is healthcare. I'll start my remarks by asking a few questions just to get a sense of the audience here. Who here, put your hand up if you've heard of the Cleveland Clinic. Yeah, okay. Put your hand up if you've heard of Mass General Hospital. Put your hand up if you've heard of Beth Israel Deaconess. Okay. Now, I'm going to list a whole bunch of organizations. And if you've heard of any one of them before Dr. Manaha had mentioned them, put your hand up. Lynn Community Health Center, Fenway Community Health Center, Bowden Street Center. All right, fewer hands, right? These are all community health centers, and I've listed a number of them. All right, now I'm going to get into audience participation part of this a little deeper. In 1965, the first community health center was established, and quite quickly the second one. There's a little bit of debate as to whether or not the first one was in Mound Bayou, Mississippi, or Columbia Point of Boston, but let's not go there for right now. Same guy was involved, a guy named Dr. Jack Geiger, who went to South Africa as a medical student in Boston on a rotation. And he saw in South Africa that delivering healthcare was about, and doctoring was about digging latrines and putting screens on doors to prevent malaria and making sure that people had enough to eat. That was healthcare delivery there. And then he came back and he went to Mound Bayou and he found that the same conditions in Mississippi were what he saw in South Africa. And so you know what he did? He started digging ditches for latrines and putting screens on doors and making sure people had enough to eat. And then he came back home to Boston and he went to Columbia Point and he saw the same conditions there in the housing project that had been built. And maybe not have to dig latrines, but there's a whole lot of other, what we call social determinants of health. I like to call them societal drivers of health that he wanted to address. And he began addressing them. And so in '65, the first two community health centers were established. He got the support of some of our local politicians like Ted Kennedy at the time. And we were off to the races. How many community health centers are there in the United States now? Give me a number. Anyone? Come on. You've had breakfast, you've had coffee.
8,000.
It's a nice number. Anyone else? So the 8,000 number is actually a very interesting number because it sits between the number of institutions, which is 1,400, and with each institution having on average 10 sites, the 14,000 sites that there are. So you're pretty much in the ballpark there in terms of the impact that we're having. Massachusetts, how many community health centers do we have? Anyone? 52. 52 community health centers. And we are about the business of providing health care of high quality. If you go to a community health center, the quality of care that's delivered there meets or surpasses what you get in your average local primary care practice, 1 or 2 or 10 doctors who are practicing. It's been statistically shown the quality of care is equal or better than what you receive in a primary care practice of average size in a community. But that's not all. Wait, there's more. We do it at lower cost. So we are a very well-kept secret in that regard. But as Kiami said, the other secret to this is that really at Greater Lawrence, for example, 55% of our patients are on Mass Health, which is the state Medicaid program, which leaves a lot of room for people like you and me who are not on Mass Health or on Blue Cross Blue Shield. Maybe they're seniors on Medicare, and they're receiving their health there too. So the history of community health centers has evolved to the point now where we actually care for 31.5 million people across the United States. They call community health centers their home. And as was said earlier, 95% of the health care that you need is actually not in a big Cleveland Clinic or Mayo or MGB. When you need that 5%, thank God they're there. Thank God they're there. Fantastic care. I've had care at MGB. I broke my neck snowboarding once. I was trying to show off to my son. And thank God MGB was there because I'm here now. But 95% of the time, you just want to see your doctor, right? You want to check in, make sure your blood pressure is okay. If you have diabetes, which is very common now, that too, maybe your arthritis, 1 or 2 conditions that you just want ongoing care. So we deliver that and more. We also address those societal drivers of health. So my experience with community health centers started back when I was on the board of Beth Israel Deaconess. And they said, we have these community health centers. Board members are, entitled to go visit them. And so I did something that apparently people don't often do. I actually did that. I visited a community health center and I was amazed. Because the executive director of the Bowdoin Street Health Center sat me down, told me what they do, and then told me about how they are very creative in solving the upstream problems. So for example, imagine you're diabetic. Imagine that you have to take insulin. Where do you keep your insulin? Anyone? Refrigerator, right. What happens if your circumstances in life means that your electricity bill has gone unpaid and your electricity is shut off? How good is your insulin then? How good is your diabetes control then? Right? That is a societal driver of healthcare. That person ends up with high blood sugars in the hospital, in the ICU, and it was all preventable by having a conversation with the utility company at the health center to say, hey, here are all these people, they're having trouble, what can we work out? Can we work it out? And they do workouts once a week at Bowdoin Street Health Center. Those are the kinds of digging latrines and putting screens on doors that in our society we have to face and address. And it can happen to any one of us, right? You don't have to be on Medicaid for that to happen. Food insecurity is another one. And we think of food insecurity as those poor people, right? 1 out of how many people have food insecurity. You would think the number's 20, maybe 15. It's 3. 1 in 3 Americans face food insecurity, which means that that's happening not only in Andover and Haverhill, but it's happening in Wellesley and Weston as well. So when are we as a society going to get serious about addressing food insecurity? You come to the community health center. Greater Lawrence Family Health Center runs with the Greater Boston Food Bank a mobile market, one Saturday a month, towards the end of the month, usually the third Saturday. We clear out a parking lot, a big truck pulls up, and 1,300 pounds of food is distributed over the course of 4 hours there. And let me tell you, the line goes around the block. All right, rain, snow, sleet, sunshine, hot heat. The line is around the block to get 2 bags of food. And I and many other volunteers who either work at Greater Lawrence Family Health Center or had worked there and know how important this is, come back to do the food distribution, put things in bags and hand it out to people. I've done it countless Sundays. I brought my kids and my wife to do it countless Sundays. I invite you to come and experience that as well. There's nothing more gratifying than giving. But the food insecurity is in our communities and we can address it. We have to address it. Because if you don't have the nutritional needs satisfied, you're much more likely to fall sicker and sicker in your illness. So these are societal drivers of health that we have to address. But unfortunately, wait, there's more. There was this thing called COVID that happened. Now, Greater Lawrence Family Health Center, we have under our umbrella about 70,000 patients cared for by 120 doctors, about a staff of about 800, so similar to Lynn Community Health Center. We don't have a behavioral health staff and unit, which we are building up rapidly this year. Carlos Capas, Dr. Capas is coming to help from Lynn to help us sanity check our plans for building up behavioral health in the next few years, starting this year. But during COVID, everybody had behavioral health issues and needs. And it just really exacerbated that between the Columbia gas explosion and COVID and a few other things. So we have to really take a hard look at what we're providing in terms of services. COVID really stressed us out. We did 150,000 vaccinations. And many of those vaccinations were for employees of small businesses in the Merrimack Valley who said, where do we find vaccines? Can you help us? And so we sent teams out there. So there is a natural partnership that the Greater Lawrence Family Health Center can have with businesses in the community. I just want to emphasize that as well. One other scourge in America right now is substance use disorder, and that affects every community, every family. I went to Harvard undergrad, Yale Medical School. My sister went to Vassar. My other sister went to Harvard. One went to U of M. We all are highly educated, black people in America. And yet my sister, who followed me at Harvard, dated a guy who died from a drug overdose. And my daughter, who went to Yale like her mother, dated a guy who died of a drug overdose. This is in every family, folks. When are we going to wake up and just admit that it doesn't mean anything whether in terms of who you are, where you come from, if you have a substance use disorder. You are a person who needs help through that challenge. It can happen to anyone, any family. Just recently, EOHHS, thank you, Kiami, put $70 million available to community health centers for capital projects to build new resources. Part of it was on an equitable basis, distributed based on either the number of centers that were eligible or the number of lives that they had in their practice. Part of it was competitive. About 20 million was competitive in 3 or 4 grants of no less than $5 million. We won a $5 million grant in that competition, and we're awarded another $2.5 million in the equitable distribution, leading us to $7.5 million, which I will leverage. So if you're a lender, let's talk. I will leverage into being more like $10 or $12 million. But one of the things that we're doing is expanding our site where we do harm reduction, needle exchange, clean supplies, and the like. testing for hepatitis, testing for HIV. We're expanding that site to now include medical services, meaning doctors doing physical exams and physicals and medical checkups for these individuals, putting behavioral health there, adding dental, which we've never had, which is a tight correlate of health in all the studies that you can find. And we're going to add all these services to our site and expand it, double the size of it on 100 Water Street. So that's a project that's coming, that comes out of our assessment of the community needs. The last thing I'll mention is that in Lawrence, in particular, if you compare it to neighboring communities like Andover, North Andover, or Haverhill, whatever the rate is for whatever disease you want to find, with the exception of hypertension, but the rate of diabetes, of cancer, of behavioral health issues, whatever it is in Andover and North Andover, double it for Lawrence and triple it for Haverhill. Think about that. And that's not because these people are genetically different, right? It's because the societal stressors and factors and the access to care that they have are different. And so what we have to do as a community, because these are the people that are going to be your workers, right, is we have to get serious about driving those societal conditions. The last thing I say before I turn it over to our next speaker is, Kiami is completely correct that we have to think hard about our workforce issues. And he said we have lots of hypotheses. I have mine, so I'll share them with you because you asked. Didn't you ask? Yeah. I think what we have is, and I've got a few letters after my MD, which suggests that I may have studied something like this a long time ago, but it's called a market failure. MGB has 10,000 open positions, yes? Beth Israel Deaconess has 5,000 open positions. I'm on the board there, I know. Maybe it's 4,000 now. But it's a lot. Those two institutions, 15,000 open positions. Let's not even talk about the other hospitals and the biotech sector, which I used to study and consult to. Plenty of jobs out there. Lawrence has one of the highest unemployment rates in the Commonwealth. And you can go to New Bedford and other places as well. Holyoke, right? Plenty of people who actually need work can't find work. Can't find one of these tens of thousands of jobs. Folks, that's called a market failure, okay? Supply and demand are not finding each other. So what are the barriers getting in between that supply of people and that demand for bodies to work? What's getting in the way? I hypothesize 4 or 5 things. Number 1, training, okay? But there are training programs out there. We just need to get people into them. Well, how do you not get people into training programs? Number 2, transportation. Okay. There's 26 miles between Lawrence and Boston. It's a marathon distance. You could run it. All right. We can't get people down there despite having a commuter rail. That's a market failure. Number 3, language barriers, right? A lot of the people here come straight off the airplane from Dominican Republic or Puerto Rico, and English is not their first language. Well, you can teach people English, right? Are we serious or not, right? And the 4th one, which is really probably the hardest one, is that 50% of our eligible workforce we take out of the market because we don't provide adequate, as a society, childcare. We let that be a voucher program, which we know doesn't work. Hasn't worked, never worked. The wait list on the voucher program is years long. So if we want to get serious about solving some of these problems, let's look at the upstream drivers of these and get to work. Thank you.
I'm always amazed when I come to these programs because we don't tell the speakers what to speak about. We just ask them to speak about healthcare from their perspective, and I learned so much. I work in Lawrence. Chamber is headquartered in Lawrence, and I live in Haverhill. I never knew that statistic. I'm an elected official as well, and I've heard these challenges, but never to that degree. I'm also the former chairman of the Massachusetts Workforce Investment Board and the former chair of the National Association of Workforce Investment Boards across the country. This issue of labor participation has been critical to the success of our future economy, and it's something that no one really knows yet, unfortunately, how to handle it to the way that it should be handled. Because every single one of our businesses, as we heard again from Dr. Fish, is in trouble with respect to finding a labor force. We need to do so much, and childcare is a critical component. It's finally been identified as an opportunity to help put people back to work. Language is obviously a critical issue, and we have a number, but not enough, adult basic ed services, English as second language services, and so on. And we have billions with a B of dollars for training. We just need to get the people into those training programs. Yesterday, Michael and I were visiting a commercial bakery. They said, we need help. We thought he was going to ask for a baker. You know what he asked for? A welder to help repair the machinery. It's amazing. Every single company that we visit every day is always on this issue. So I understand the challenge, and I thank you both for your leadership. And now, we're going to hear from another leader. I want to introduce, and I don't know what all these initials mean, but I'll say them anyways. Robin Hines, MSN, RN, CP, HM, you have to tell me which that one is. I know what the first two mean. And she is the interim president and CEO of Lawrence General Hospital right here in the Valley. Please welcome her.
Thank you, everybody. It's great to be here. Thank you, Joe. Thank you, Michael. Thank you, Guy. Thank you, Kiami. You sort of set it all up for me, so thank you very much. So Lawrence General Hospital is a community hospital, and I do want to say that community hospitals are your first line of defense. If you're having a heart attack, if you're getting into a car accident on 495, if you're having a stroke, if you're having some sort of major trauma issue in your life, whether it's, an accident at home or your child is having some sort of asthmatic, situation happening, this is where you're coming. This is your first line of defense. You are not driving that 26 miles downtown. It's just you're not. So this is where community hospitals are really the vital thing for healthcare in any community. And Lawrence General Hospital spends a lot of time making sure that we have high quality, high value healthcare available and affordable in the Merrimack Valley. So I wanted to just tell you all a little bit about us and some of the things that we're working on at Lawrence General Hospital. And if you have any questions, I'm happy to answer those. So, and some people may not know some of the things about us. I've been meeting with a lot of different community members and potential donors and staff, and I don't think we get our name out there enough in terms of all the great work that we're doing. I think a lot of you may remember us, especially during the COVID crisis, where we serviced the 8-lane testing site, which many of you may have sat in that line for very long periods of time. Yeah, exactly. Well, we delivered about 350,000 tests during that time. And that was a moment in time that we all came together, working with the city, working with the state, working with community leaders, and making sure that we made available to everybody in the community what was needed most. So just for a little bit of background, we are a 186-bed not-for-profit hospital. We are a standalone hospital, so we are not part of a system, and that is a little bit of a unicorn nowadays, especially in Massachusetts and also across the United States. And so some of the things that the Undersecretary was speaking about in terms of rates, in terms of, payment structures, that's something we're constantly having to battle. We have to go to Blue Cross and to Harvard Pilgrim and to Tufts and negotiate our own rates. And we don't have large, staying power, unfortunately, from other bigger institutions to help us do that. So it really is vital that we get paid fairly and that there's parity in the payment rates. For government payers, which we're 70% of, Medicare and Medicaid, as Cami had said, it is pretty much a standard rate, everybody gets paid the same. But for commercial insurances, if you come from a larger entity that's able to negotiate large rates, you get paid more for the services that you're providing. So for instance, if you're getting a mammogram, say in Wellesley, at Newton Wellesley Hospital, Newton Wellesley Hospital is making significantly more for that mammogram than Lawrence General Hospital is. Even though it's the same level of care, it's the same high quality, there's no differences. Same thing for Mass General Brigham, same thing for Beth Israel downtown. People get paid higher based on the rates that they're able to negotiate, which that's not fair. I mean, that's just not fair. It's not health equity. It's not, people deserve to be able to be paid fairly. And so we at Lawrence General Hospital are working very hard to do that. I was down at the State House yesterday. Many of members of my team had an opportunity to testify on behalf of the rate parity bill that Representative Frank Moran is putting through. So if you have a chance to check that out, please do so. We'll be down next week also in support of the Health Equity Compact bill and testifying how that impacts Lawrence General and the people around Lawrence General Hospital, and not only just in Lawrence, but also the surrounding community. We do about 350,000 patient encounters. Our emergency room is quite busy. We service 65,000 emergency room visits. We're a level 3 trauma center. We're the only trauma center in this area. So as I'm saying, you get into a car accident or something happens from a traumatic standpoint, we're at the ready to take care of you 24/7. We do significant amount of births at our hospital, around 1,500 births. We work very closely with the health center on that. It's a great partnership with our family residency program. And we're the sole inpatient pediatric unit in the area, which these are essential services that we're fighting very hard to keep in our community, very hard. Again, but without rate parity, it's something that will be something we'll have to look at in the future. We are obviously working very hard to bring on as many providers. Again, we're working very closely with the health center. We do about 400 medical staff providers that are affiliated with Lawrence General Hospital. We're very high volume. We are a key community partner advancing diversity, equity, and inclusion, and I'll talk to you a little bit about some of that, which is part of our strategic plan. We are one of the only hospitals accredited in several critical areas, especially around the heart care center. So when you're coming for a heart attack or heart pain or chest pain or anything like that, we have received the Heart Care Center Award 6 times in the last 6 years. And that doesn't happen for every hospital, even in academic medical hospitals. This is a pretty prestigious award that you get, that you have to meet every measure in order to receive that. And it's usually looking at your door to balloon time, meaning if you come in the hospital with a heart attack and you need to go to the cath lab, every minute, every second counts. And our door to balloon time is way below the national average, and therefore we are really, again, at the ready to take care of you, whatever you need. We also have the full complement of services across the spectrum of care. We do med-surg, we do surgery, a cardiac, ICU. I have 24/7 intensivists here in our ICU, which is a 19-bed ICU. It was done over in 2017. State-of-the-art ORs were also done over in 2017. You can have your surgeries locally. You don't have to go downtown to have many surgeries. Please check us out online, and we'll be able to describe some of the programs that we provide for you. We also have a large emergency medical service where we actually work with the city of Lawrence and a number of surrounding towns where we have an ambulance provider providing paramedic and EMT services. We also have a lot of ambulatory outpatient areas. So, thank you talking about getting your mammogram. We have multiple sites for mammos in Lawrence and in Andover, and also we have a site co-located in Methuen, a number of off sites in North Andover and Andover. So Lawrence General is out there making sure that we're providing not only the acute care that you need at the hospital, but also from an ambulatory perspective. I talked a lot about all the distinctions that we've had in terms of quality. We just recently get with the guidelines Gold Plus and get for stroke and get with the guidelines Gold for resuscitation. These again are not, easy to achieve accreditations. We work very hard to make sure our providers are up to speed and everybody's getting what they need to do from an education standpoint. And one of the also things that I'm very, very, very proud of is that we received an A from the Loan Institute Hospital Index, which talks about the social responsibility and how community hospital really, addresses a lot of the social determinants of health that Dr. Fish was talking about. And we are a partner in that and continue to be that, not only for our local providers like the health center, but also for the state. So I'm very proud of the organization that we have and what we've done here and what we can provide to you. And I think sometimes we become a little bit of the best kept secret in healthcare because I think, again, people think about the brand and not about always the value and, the access. And really that's what we're focused on is access to care. And I know it probably timing is an issue, but I just wanted to we just finished our strategic plan back in April, and we are working on the 5 E's of excellence, and I'll just kind of give you a little bit of what those are. So we're enhancing our community and patient perceptions, so working on our own brand awareness, making sure that we're delivering seamless customer service care. Love to hear from any of you if there's opportunities for improvement. My door is always open from that perspective. And really working on amplifying our community outreach. We've been doing a lot of work, as I said, we did with COVID, but we are doing a lot of work now getting into the community, working on blood pressure screenings, working on getting children access to bike helmets and safety helmets and checks for car seats and things like that. Connecting people to primary care, which is a needed service in this community. And we work very closely on making sure patients get connected to the health center, especially when we're identifying high blood pressures that people are walking around with. And I'm not just talking about Lawrence, I'm talking about Andover and Methuen and North Andover. Again, it is about ensuring that you get access to preventative care and seeing your doctor every year and having those things checked, because as much as I tell you all the things that we're ready for and available for, I'd rather you be managed in the community and stay healthy and well. And then if you do need us, we are there. The second pillar that we're working on, as I had mentioned, is elevating our health equity and diversity, equity, and inclusion. So we're doing a lot of work on education, ensuring belongingness, so that working on our diversity of our staff, bringing new people into the organization so that we can generate new ideas and new services and new access. We have a DEI roadmap that is, it's a journey. It's going to take us a long time, but we are on that journey and moving that forward. And not only are we focused on our staff and our providers, but also our board of directors is very engaged in that as well. We're emerging as the provider and employer of choice. We talked a lot about staff that has hit Lawrence General. I think I was here maybe last year or the year before, and I was talking about all the open positions that we have. I will say we still have a significant amount of open positions available, but we've done a lot of work on trying to recruit new staff, change from this contract labor situation that we've been paying 3 times as much for a nurse than what I would normally pay, because I just have to have nurses and techs and everybody else in a healthcare community to take care of patients. And sometimes the prices of having to pay for those have been astronomically high. And over the last year and a half, it has been a real source of stress on the hospital. So we are working very hard to make sure that that is being brought down, that we're recruiting staff. I will say from last August, I've recruited over 129 nurses. So this is and I still have plenty open positions, so don't think I don't. But this is great news, because it's better to have someone that's in your organization, working for your organization, committed to your organization, feeling like they belong and part of that organization, rather than someone that's doing a 13-week rotation and changing their places of work every 13 weeks. It's not good for healthcare. It's not good for patient care. And we're working very hard on bringing more providers and services, having some communication with the health center on ways in which we can partner together to bring on new specialty providers just to help support a lot of the primary care work that's happening at the health center, and then to many of our other primary care doctors. And then obviously working on establishing our financial sustainability. I will say thank you to the state that has been very helpful to us through COVID the last 4 years. I will say 4 because March 2020 will be 4 years, if you can all believe it. It feels like a lifetime ago, but some days it feels like a lifetime and some days it feels like a blink of an eye. It's very confusing time warp we all live in. But yes, it is. We have been working really hard to ensure our financial sustainability, and the conversation I had on rate parity and explaining to you, the way in which you get paid from a commercial insurance provider. It's really important for us. We're in our contracting up renegotiation time period. We're going to be working with our providers. We have to still work on decreasing that contract labor, that contract labor spend that we're seeing. Again, open positions, referral bonuses, lots of opportunities like that to bring in people that really want to be part of Lawrence General family. And then coming up with some innovative ways in which we can grow service lines and grow different kinds of business lines and partner. And so that is one thing I wanted to stress too. We are very open to partnering with community members, with other organizations, coming up with ways in which we can continue to provide that access, but do so in creative, sort of diverse ways. So please see me after if you have any ideas. I have plenty of them, and I'm happy to have those conversations. And then our last pillar is looking at our innovation and ways in which we can use technology in a better way. A lot of hospitals are moving to this hospital-to-home model or hospital-at-home model rather than having to sit in emergency rooms waiting for the care, waiting and having care, taking so long to get access and move patients through the system. And so we're looking at ways that we could potentially provide that, especially with our EMT service and our ambulance services that we have. So I know I'm probably over, and we are a mission-driven organization. Again, community-based. We are here for you. And if you have any thoughts or questions, I'm happy to answer those, but I know it's after. So thank you.
Thank you. And we will take questions after Jennifer speaks. We'd like to now introduce Jennifer St. Thomas. She's the Senior VP of Sales and Medicare Product for Mass General Brigham Health Plan. Welcome, Jennifer.
Hi, everybody. Thank you to Joe and Michael for this opportunity, and just have really appreciated the remarks of these healthcare community leaders, and certainly energizes me to bring a lot of this good feedback back to the office at Mass General Brigham Health Plan. So really quick, I'm just going to hit a few themes. Just wanted to introduce who we are at the plan. Mass General Brigham Health Plan has been in business for over 30 years. We have 385,000 members. We work with employers of all sizes, and we also support members that are over 65, our seniors in the community with our Medicare Advantage products. And then we also work and support and partner with the Commonwealth of Massachusetts with our Mass Health population. So we really work with everyone within this community, and we have a network of providers that is extensive. So although we are owned by Mass General Brigham, we have every provider in Massachusetts is in our network. Certainly Lawrence General Hospital is in our network, the health center is in our network, and we work very closely with other providers. And a big piece of that is because we are a provider-owned plan. We understand the challenges that providers may face. We understand how to work with them and how to really help be that bridge between the employers and our members and that provider community. And so one way that we did this over the past year was the feedback around the mental health access challenges. This was a universal, when we polled our employer group customers, their top issue was mental health access, particularly for adolescents. And that cascades into so many issues in our provider community in terms of clogging the emergency departments. And so we really looked at the system as to how do we tackle that. And we essentially worked to partner with Lyra Health to buy that access and be able to redirect those premium dollars to provide that guaranteed mental health access in an average of 2 business days for all of our commercial members, and really built that into our products. And we feel really good when we have those conversations with employers now that we have a solution from age 0 all the way up to 100 plus to be able to make sure that they can get that care that they need. And we first rolled this out with our employee plan, because as frontline healthcare workers, we saw that issue in an acute way. And what was really interesting is almost everybody that accessed that additional service that we provided had never had a mental health claim. So there was really this pent-up demand, this unmet need that we were able to step in as a health plan and provide that solution. So that's the mental health piece. The other piece I wanted to emphasize was our commitment to local service. You know, this is something that we really believe in, being able to be a health plan that can put the member first, that's not putting shareholders first, that's a nonprofit plan that's able to make the right decisions by our members and provide that needed service, because when you're accessing the healthcare system, it can be a very confusing time. When you're turning 65, it can be a confusing time. And we are here to be in this community, work and partner with both businesses, with individuals, with our broker partners to help make sure that we are providing the best possible service that we can. And we were just acknowledged by J.D. Power as the #1 health plan for member satisfaction. So Blue Cross had it for 6 years. We are now #1, which is great to share with this audience. How many awards do you get as an adult, right? It's very exciting. So that's really that third-party validation of the work that we've been doing at the plan to really make sure that we're helping everybody when they need it the most. So really appreciate the time today, appreciate the other panelists, and I'll turn it over to you, Joe, for questions.
Thank you. I know that some of you are leaving because the expo is opened, but are there any questions or comments? We had a tremendous panel. I think that everyone inspired some discussion, some thought. If you have any questions, please feel free to ask them. If not, the speakers will be here for a few minutes and you can ask them after the program. Any questions or comments? Anything from the panel? I just want you to know that this is taped by Lawrence Community Television. It is distributed to the 10 local cable access stations from Newburyport to Lowell. It's also placed on YouTube. It'll be part of our social media program as well, so there'll be a great opportunity to see this again. And again, I want to say thank you to our speakers. We really try to bring the best speakers forward that really make a difference in terms of your lives and your business lives, because these are issues that you face on a day-to-day basis. And I mentioned earlier, healthcare is the #1 and #2 issue that every business faces. Every time a new member joins, they ask us about healthcare. They ask us, where do we go? And we tell them, you don't have to drive to Boston. Thankfully, we have great service right here in the Merrimack Valley. So thank you to our speakers. Thank you to all of you. The expo is open. It is free admission. And then we'll see some of you back here at lunch for the NFL agent. Thank you so much. Have a great day. And see you at the expo right next door.